So good morning once again, and welcome to our January 2024 Knowledge Cafe for I-Cords. I am sitting in today for our community manager, so happy to be hosting you today on behalf of I-Cords. For those of you who are joining us for the first time today, I-Cords is a community of practice that centers around the social and behavioral sciences in the field of neglected tropical diseases. Our purpose is to bring people into this field together to learn and collaborate with each other. And one way we do that is through our knowledge exchange cafes. And this is an opportunity for us to hear from experts in the field and to hold a discussion on the concepts that are shared and learned. So as we get going today, please feel free to put any comments or questions that you might have in the chat. And we'll also have time at the end of the session, a good portion of time for a discussion together. So my name is Allison Krentel. I'm an associate professor at the School of Epidemiology and Public Health at the University of Ottawa, and also a scientist at the Brea Research Institute. So I'm based in Canada. It's snowy out today and cold, -15, I think, when I woke up. Envious of all of you sitting in warmer climates today for sure. Our speaker today is Dr. Carol Vlassoff. She's an adjunct professor with the School of Epidemiology and Public Health and the Brea Research Institute. Carol has conducted research and teaching activities in the field of global health, gender and human rights, and NTDs for the past 12 years. Formerly, she worked with the WHO, including many years in senior positions with PAHO, among those chief of the HIV/AIDS section for PAHO, and also the PAHO representative in Suriname. And if you want a historical paper, Carol wrote one of the very first papers on the intersection of gender and tropical diseases. So it's a seminal paper that kind of made that first link that we now need to spend a lot more time on, I think, as a community. So delighted to have everyone here today, and I will pass over to Carol for our presentation. So thank you, Carol.
Okay, thank you. I'm just going to share the screen here. Yeah. Here we go. Sorry, I have to go to the beginning. So good morning, everyone. I'm delighted to be able to be invited to present to you something that's very dear to my heart. I've been working on this framework, applying a gender-sensitive and human rights-based framework to different diseases, well, actually only to two. First to Zika, and then to female genital schistosomiasis, which I'll refer to as FGS. This presentation is based on a paper by myself and several co-authors, Kasim Arugundadi, Kruti Patel, Julie Jacobson, Margaret Gyapong, and Allison Krentel. And we published this in 2002. So really totally based on this collaboration. So basically, the objective today will be to describe the framework, which is a human rights and gender equality-based framework, which can help guide country responses to FGS in a holistic way across all components of the health system, respecting human rights and gender equality obligations to which most countries of the world are already committed. And then to propose some specific action for the health system, which should be based on these key components of the health system, and also on the key components of the FGS accelerated scale together, which is better known as the FAST package, which Allison and colleagues have been testing and refining in different countries, and we'll come to that in a minute. So basically, there's a number of very important international commitments to human rights, and then to health as a human right, and to gender equality. So the WHO was the first, as far as I know, to express it formally and to ratify the right to enjoy the highest attainable standard of physical and mental health. And this was introduced in 1946. So even before the the Universal Declaration of Human Rights by the UN in 1948. But in the 1948 declaration, it's more spelled out. Human rights, of course, are spelled out in much more detail, not only for health. But it also really emphasizes women's rights, and this was ratified by almost every country, as I said. So the human rights-based approach to health, I'll talk more about this later, but it's an important ethical benchmark. It's a benchmark for health, for development, for many activities within many of the goals within the MDGs. So it's actually in the 2030 and Sustainable Development Goals agenda. The right to gender equality equally has been ratified by most countries in the world, and first being in CEDAW, which is the Convention on the Elimination of All Forms of Discrimination Against Women, 1979, and then reinforced by many subsequent agreements, which requires protection of women's fundamental freedoms and human dignity. And this is also UN, I think 1979, but then put into force in 1981, I believe. All of these wonderful declarations, and they truly are wonderful, but really have not been seen fruition in most countries, I would say. The incorporation of gender and human rights approaches into health policies and programs, for example, remains fragmented, and access to the full set of sexual health and sexual and reproductive health services and rights are really unfulfilled. And within this, FGS is a perfect example. So just to talk a bit more about the human rights-based approach to health, I mentioned that all member states have ratified at least one, all member states have ratified at least one international human rights treaty. And this should be important because countries have signed onto them. The right to the highest attainable standard of physical and mental health is enshrined in international legal instruments, including the International Covenant on Economic, Social, and Cultural Rights. Entitlements include the right to access quality health services without any discrimination. A human rights-based approach to health commits countries to develop rights, gender transformative, rights-based, effective, gender transformative, integrated, accountable health systems, and implementing public health measures that improve the underlying determinants of health, like access to water and sanitation. We'll come back to that. So this means that countries really must ensure that they have legislation and health policies and programs that really do advance the realization of human rights. So these are all of the commitments to kind of give us some background. So what does this really mean? So what are the nature of the obligations that are expressed in this declaration? So we have the duty bearer, which is the country normally. But in this case, in our case, it's one of the country's ministries, which is the Ministry of Health, so the health sector. But it could be applied to really any sector that is a public health sector, public sector. So the duty bearer basically is that which gives the services or what the services to the countries. And the rights holders are the population, us, the clients. And we don't just sit there and wait for these rights to be fulfilled, but we also have a duty, which is to participate and claim the rights from the duty bearer. So we need to be aware of their existence and that we have a right. So we cannot simply just assume that they are going to come to us. And so we have to motivate for them. And some of these obligations have immediate effect. And that was back at the time of the Declaration of Human Rights. And they were to have immediate effect then. And then some were subject to progressive realization, which meant that countries which were unable, very poor countries, for example, who were unable to fulfill all of the rights, were given the right to progressive realization, so they could do it progressively, but they could not go backwards. So once you reach a certain stage, you cannot go back and change those rights. And we know many examples, very, very current examples, where this has not occurred, that actually rights that have been obtained with a lot of trouble, a lot of work, a lot of motivation, have actually been totally reversed at the highest level. So we've seen that in neighboring countries to Canada, for example. So our approach then should be to focus on gender equality as a part of the fulfillment of human rights, as well as on equality and equity in other attributes as well, like age, ethnicity, race, religion, health, socioeconomic disability, sexual orientation. So all of these are obligations and worthy of equally deserving of AAAQ. This was written in as well. This is taking it a little bit step further, which is availability, accessibility, acceptability, and quality. So now turning to female gender schistosomiasis. Well, we know that it's one of the most important neglected infections in women's and girls' health globally. However, knowledge about it is relatively recent. Data are not systematically collected by health systems. There's no official case definition for diagnosis. And its symptoms mirror those of other diseases such as sexually transmitted infections, like vaginal discharge, ulcers, genital burning sensations, and also menstruation because of the blood in the urine. So it can often lead, and has led traditionally, to a lot of misdiagnosis. So there's a need to review the algorithm and syndromic management protocols for FGS, for female genital tract disease and schistosomiasis-endemic countries. And so WHO recommends that a diagnosis of FGS should be considered in women and girls with urogenital symptoms and a history of contact with fresh water bodies in schistosomiasis-endemic areas. So often neglected, often misdiagnosed, and this is a way of trying to refine and make diagnosis more precise for FGS. It's treatable and curable even with a single dose of praziquantel, especially if diagnosed early, and yet it's limited. There's very limited availability of praziquantel for primary healthcare facilities, yet it is included in WHO's essential medicines list, but unfortunately it's not available everywhere, and certainly not at the first point of care where people need it. It is very much, I think all of us here probably recognize it, very important gender and human rights issue, not only because of its biological manifestations, which are still not completely understood, but also for the wider social and economic inequalities, which place women at special disadvantage, physically and socially. It's still widely regarded as a boys' disease, because mainly, I think, the blood in the urine, when it's seen more commonly in boys who tend to urinate publicly or more publicly than girls. Males are less compliant with mass drug administration, and thus they may harbor infection and sustain transmission in some settings. Girls are put in frequent and constant contact with water in most schistosomiasis-endemic areas because of their household domestic responsibilities. So whereas boys tend to use the water more for leisure and swimming, which is also very frequent, girls tend to be obliged to use water for their domestic work. There's gender inequalities in access to resources, like income and education. So this is also associated with poor health and poor and well-being. The consequences contribute to physical and social disabilities, such as infertility, which impact productivity and therefore social status, ability to work, and poverty is exacerbated because of the lesser ability to contribute productively. And the confusion of its symptoms with STIs and HIV creates fear of stigma, and the shame that is attached to infertility is a particular concern for women because of the high societal value attached to motherhood. So these are all a number of, there are more, but these are a number of important gender and human rights issues linked to FGS. Fortunately, there's increasing attention to it as an urgent human rights issue, also as a development and reproductive health issue. In December 2019, UNAIDS and WHO launched a call to integrate FGS into women's health services. There's some attention to the issue in recent academic publications and also to human rights, as I mentioned, as an important human rights issue. BRI, the BRIA Research Institute, has had pilot projects in some endemic areas, including Guyana and Madagascar, and is currently working on a new project in Ethiopia, I believe. But no country has yet fully incorporated it into its health system, guided by human rights mandates and the redress of FGS-related gender inequalities. So this is the framework that we're proposing that discusses, that describes the reciprocal relationship that we saw earlier between the duty bearer and the rights holders. So if we see here, we use the example of FGS. So on the top is the health system and their obligations, their human rights, talking strictly about human rights at this point, not gender. So these are the human rights-based obligations, and the clients, the receiving, are the bottom row here, the clients whose responsibilities are to motivate for access and equity. We have put all of the building blocks. I don't know if everyone's familiar with the building blocks of the health system, but they have been in, I think, since 2008. Recommended by WHO as a way of looking at looking more organizationally at the health system. It gives you a way of kind of dividing up a very large body of activities, services, policies. So we have the leadership and governance, the health financing, health workforce, health services, medical products, medications, and information, research, monitoring, and evaluation, all of that part. Then under the gender-related programmatic obligations for FGS, we have the FAST package, the 4 FAST package interventions, recommended interventions, awareness raising, prevention, training, and diagnosis and treatment. So basically that shows you in a graphic way how we interpret the human rights based approach to work. So once again, we see here the right to health incorporates healthcare, which has to be AAQ. And there are also the underlying determinants, which are water, sanitation, food, nutrition, housing, many other conditions that determine the right to health as well. So now applying the human rights relationship to the reciprocal relationship to the health system, the duties of the population, sorry, should go one up. The duties of the health sector, these were determined in the Declaration of Human Rights too. The health sector is certain ones were absolutely the responsibility of the health sector, which are the access to discrimination-free health facilities, goods, and services, access to essential drugs, equitable distribution of health facilities, goods, and services. So these are solely the responsibility of the health sector. And two are shared with other sectors, which are the access to nutritious food, access to safe and potable water. So here, the health sector is not solely responsible, but they do share the responsibility with other sectors. And this is particularly important, I think, for FGS because water is such an important component of transmission. And so these are, but these for our purposes, we've not yet tackled the other intersectoral ones, but we only are focusing on these three obligations with the health sector. And then the other side of the rights holders, they're bound to be aware of all of these three obligations, that the obligations are to them, and they have to mitigate for them. And the same other two with other sectors. So from the health system perspective, the part one of the framework, this is how we analyze it. The building blocks are on the one side here, and across here are the four components, or the four major types of strategies and interventions for FGS. So we've just put them across here. I leave it blank just to give you the idea of how it's set up. And here, are these gender related when it comes to the gender obligations, which we'll come to in a minute? Are these being met? Yes, no, comment, or partly. Part two, from the client perspective, or the population. So we have the obligations here, the three core obligations, and over along the other columns, we have the benchmarks, available, accessible, etc. So then now using the example of FGS, part one, which is the health system perspective, we filled in a few here. The paper has many, many more. And we've only filled in the two top ones, leadership and governance and health financing. The other ones, however, in the paper are filled in, and there's a lot more activities, policies, programs in each of these as well, in each of the other columns, in each column rather. So just thinking at the time, I'll give a few examples here. Under leadership and governance, of course, policy is extremely important. So what would they need to do? Well, one of the things is to promote cross-sectoral programs, or the importance of raising the importance of FGS in all the different programs that have something to do with it, as a very important neglected human rights, gender, and SHRH issue. So this is an example. If you were country A, it's just a fictional country. Country A formed a cross-sectional FGS National Advisory Committee. So it did meet it. And this is for the oversight function. So the cross-sectional FGS Advisory Committee could be a very important policy instrument. And in fact, this is being implemented, I know for sure, in Ghana. Margaret Gyapong has been quite responsible for this, but I'm not sure what Alison can tell us about other countries. There are lots of other policies that can be implemented. For example, commitment to ensure under prevention, we have to be sure to have high quality mass drug administration going on within the schistocontrol activities. Country A is treating only schoolgirls, for example. So we would assess that as only partly meeting their obligations. Because the entire female population should really have access to MDA. So those are we can go ahead to training, diagnosis, you can see them there. Just to give example for health financing, we could explore the health financing area should explore options for saving and mainstreaming praziquantel into the health services. For example, could they get cheaper through bulk procurement with other countries, for example? So then, did it meet this? No, country A doesn't have no such initiatives. Then simply for prevention of infection, You need to ensure funding is available for key FGS interventions, for example. Is it? Yes, country A has a lot of funds. So those give you examples of how you would fill these in, and they would be different. This is just fictional, but these are key policy interventions, of course, but each country would want to interpret them in their own way. So they're not cast in stone, they're just examples. And then coming to the population perspective, I won't go into each of these, but it shows you how you would start to work with it in terms of whether these benchmarks are being met from the client's perspective. So in terms of access to discrimination-free health facilities, goods, and services, to be available, FGS services should be available at the first level of care because that's where a lot of population is, especially in poor countries. Referrals that should be available when needed. Is this being met? No. In country B, FGS services are not available at any level of care. And similarly, let's go to acceptable. Clients understand their right to receive sensitive, non-judgmental, and quality FGS counseling and treatment. So is this being realized? Well, I put here as an example, partly because the NGOs are working to create awareness in the health sector and motivating with the population. So these are just examples. Maybe I'll just, thinking about the time, I'll just give one more from the equitable distribution because it's so important that the facilities, goods, and services not just reach some people, but everyone. Let's look at accessible. Are FGS facilities, goods, and services of equal quality, accessible to all without undue inconvenience or hardship? And just as an example, no, country C, FGS services vary in quality, perceived by clients as better in urban areas. I think that's familiar to many of us. And just one more example of acceptable. Clients of all backgrounds and attributes receive equitable services, and mechanisms exist to report perceived injustices. And the assessment here, no, because no such safeguards exist. But like with the health sector part, this is all of the interventions may be different, but the benchmarks are the same. The obligations are the same, the benchmarks are the same, but the policies and programs that are being used could be quite different. So just to the last two slides, to the strength, I think, of the framework are it's easily adapted to real country settings and FGS priorities, policies and programs, quite simple. It's applicable generally to the health system and a range of diseases and conditions. It responds to both gender and human rights commitments. I think this can be quite important for donors and international organizations, which are trying to see these commitments being reflected in their programming. And if we have a framework that can actually demonstrate that, it's very helpful. The measures can be refined, of course, according to the capabilities of different parts of the health system. The yes, no partly is very aggregate, but you might want to refine them to say what would yes actually mean and so on. It's very inclusive of the client population. It's a possibility of progressive realization so that the goals should be, but if it's progressively realized, if the rights or obligations are progressively realized, they need to be clear goals, and the progress needs to be monitored to avoid regression. And it reflects exactly clearly where gaps exist at different levels of care. Because you can see there they can assess, well, in some parts we're doing pretty well, in other parts not so well. And limitations, it hasn't been tested yet in real country settings. It remains aspirational. Measures need to have not yet been fully developed or articulated in detail, as I mentioned before. And implementing it in countries would require considerable time investment, especially by health personnel and especially at the beginning. And I think that it's still a bit awkward, the two component parts, especially when you start to put data into it. So you have to have both the health sector and the client, and you have to make sure that both are well respected. So maybe there's a way to refine that better. We tried to do that in the graph, in the figure, but I think we need to be able to perhaps express it more concisely as well when you're really trying to use it in the health system. So that's it for now. Thank you very much, and look forward to hearing your comments and questions.
I realize I'm muted, so sorry about that. Thank you so much, Carol, for a very clear presentation of some complicated ideas. So thank you very much. And there's been some one or two questions that have been brought up in the chat. So I would encourage everyone, as you've listened on and as the discussion continues, we have about 20 minutes or so for a good discussion. So please feel free to put your hand up if you want to ask a question directly or make a comment or put something in the chat, and we're monitoring that. So very happy to raise those questions. So Carol, thanks so much. And I guess as a first question, how do you see this kind of framework being applied within a Ministry of Health?
Yeah, a great question. Thank you. I've been thinking about this a lot, and I think that I could imagine when the budget planning sessions take place, for example, in the ministry, often that brings in well, I'm not sure about all countries, but I think sometimes other sectors are brought in for that planning as well, like WHO or PAHO or NGO representatives. And I think that that would be an opportunity to really use the framework to bring in representatives from each part of the health sector so that we have all of the building blocks, and perhaps devote a little time to a workshop where you have each of the building block representatives taking a part and working together, say with the NGOs, and very participatory process in identifying policies and programs that you possibly could implement and how you would monitor it. And I think that could just be part of a normal either budget or other meetings that the ministry organizes. So that's how I would see it, that they really take responsibility, then you share the information and you commit to working on it.
Yeah, no, I think that's and I think having I love the kind of reciprocal nature of the duty bearer and the rights holder, and that conversation that has to, so when we do awareness activities, for example, also it's informing communities of what their rights are, to help drive, and hopefully that would drive that process. And I'm gonna go to one of the questions in the chat, but I'm also gonna just alert both Ashley Preston and Margaret Jaipong, who are on the call, who I know have had a lot of experience working with FGS integration in health systems, and I think Christine Kalume as well is on the phone. So please feel free. I'm going to go to a different question, but I'm highlighting your names right now because I know you're on the line and you've got some experience on the health system integration. So I would, and many of you do as well. So not just the three of you, but those are three names that stood out to me. So do feel free also to think about comments that you may have. But one of the questions we have from Stephen, and Stephen, I'll read your question, but feel free to put your camera on if you'd like to add to it. So Stephen says the framework shared focuses on gender sensitivity for coherence of messaging. What are your thoughts about shifting the framework from sensitivity to gender transformative? Which is the idealized situation as proposed in the WHO Gender Responsive Assessment Scale. So Carol, I wonder if you could comment on that.
I mean, I totally think it's a very good idea. I wonder if we're at the point yet that we could really view it. I mean, really, certainly we could envision gender transformative programs, but whether we could reach that point, I mean, I think you need to go step by step, and I think transformative really means changing. I mean, you really need to change roles and behaviors and policies. They actually have to really reflect complete equality. I think it is an ideal, and perhaps we need to put that in, Stephen, into the background or somehow, because in the end, it is working towards that, even if it's one disease or one condition. I mean, that's going to help to promote gender equality. So, but I would say that it's still a process yet that we need to get through.
And just for those of you, the difference between gender sensitivity and gender transformative, or gender sensitive programs and gender transformative programs, that's language that some of you may be aware of or not. But a sensitive program is one that accommodates the gender differences in pursuit of health, where one that's transformative would seek to transform gender relations to promote equity. So it's really, as Carol mentioned, like seeking that change. And I know there's experts on the call, so really happy to have other comments on that. But it just an important, and it is a continuum. So you'll be somewhere on that continuum, hopefully, when you're adding gender to project and considering gender in a project or an intervention. I'm gonna, there's a second question, Carol, and that comes in that says there's a lack of normative guidance, and this is from Sophie Herman. So Sophie, again, very happy for you to put your hand up and make your comment directly, but I'll go ahead and read it. You mentioned a lack of normative guidance on FGS. What guidance do you think would be especially helpful?
I guess it depends which aspect of FGS we're referring to. I guess, I mean, the FAST package would be normative in terms of how to treat it, to prevent and treat FGS. Normative guidance on, maybe you could explain a little bit more what you mean by that, or for what exactly.
Sophie, are you able to put your camera on or your microphone? And then I see Margaret's hand. Okay, maybe.
Yeah, thank you. Thanks so much. Yeah, I was picking up on what you said in the beginning of the presentation around a lack of a case definition, a lack of standardized data collection around FGS. And I was wondering, it seems to me there's just generally a lot of gaps around FGS. And I was wondering, if you were to put together a WHO task force to fill some of those gaps, what would you have them work on first?
Carol, I can maybe help with that a little bit, because there's quite a lot of research that's going on right now. And I know there's a large study that's about to be launched that's going to be looking more closely at definitions for diagnosis. And I know there's also people on the call that have been working on this. So I think there's a lot of work that's going on to refine and to help health systems on the definition, the case definition for diagnosis. And I would invite people like Daniela to speak up, or Beth Long, who are involved directly in some of that research. There's also a group, FIG, and I know Anouk had to leave, but the FGS integration group that's working at the kind of that global level to try and understand how to better integrate and what kind of guidance we need to integrate FGS into existing sexual and reproductive health or HIV AIDS activities. So there is work going on to kind of try and understand those, what questions we need to, how to provide the answers and the guidance that health systems need and clinicians need in order to address FGS. I don't know, Sophie, if that helps answer your question.
Yeah, that's very helpful. Thank you. And could you just repeat the groups you mentioned working on a case
Yes,
definition?
sure. I'm happy to put that in the chat box.
Perfect. Thank you so much.
Great. And I see Margaret's hand, Margaret Jaipong from Ghana.
Hi, Alison, you compelled me to put my hand up, so I did. As always. But thank you very much. Sorry, I joined late. I was tasked to make a presentation on the new TDR strategy. I just finished that and then I jumped on this call. But it's nice to see Carol. Carol not sitting in her role as manager of the gender task force in TDR, but sitting outside and then talking about gender, linking it up with countries and programs. It tells you that once you start something, you don't let go of it. That was a beautiful framework. I mean, I saw the way you went through systematically, but my question was around the issues that Alison raised, and the issue about how programs are going to implement. Oh, they want me to confirm my language. Just a minute. Okay. Yeah.
Mm-hmm.
Around who in the program is going to be implementing this kind of tool, and linking it up with what Sophie said about the fact that there's not much out there, and even defining what FGS is. So if you are posing this question to a client who has arrived, what is the person thinking? Did you receive good services for FGS? Did you receive this? Did you receive that? Do they define FGS as we define it? Or how do they sieve out the services they have received? Because they come, and if they come to maternal health, they are receiving services for something. Let's say I'm bleeding PV, and you come, and then you go through the process of being taken care of, go and see the gynecologist, go and do a scan. And I was wondering, how are you going to decipher this from it and say that, okay, because of this, this was done, and because of that, I can say my service was specifically for FGS rather than comprehensive healthcare, because you go to the OPD, you go here, you go there, you know. So that was what was going on in my mind as I saw the tool. Very useful. I thought that, yes, a researcher can do this, but in terms of program at the health facility level, who really is going to administer that tool, or so
yeah, that's a great question, Mary. I honestly, I think you probably could answer that better than I could, but I would think that that would have to be defined actually when you have this, when you put the whole framework into the context of the country context and the health system and others. And I mean, there are different ways of doing it, but I think your question about being routine is a good one. How would you routinely do that? I can see exit interviews, yearly meetings, but you're not going to be able to do that for every disease, every condition. I think that would just have to be worked out, and you may only be able to have a few people. I mean, it may not be perfect, but at least to start to think about that they have the right, and how then would they feel? I mean, how were you treated? Did you get what you needed? But these will all be questions you have to ask. Maybe if we don't do exit interviews or special things, we really have to think, how would that be incorporated then as the client leaves the services? Or I don't know, maybe Alison has some thoughts on that as well, because he worked so much in communities. But I think at least to highlight it, it's there, and then we need to work out how to actually do it. It's a good question.
But just to add to that, do we have an example of any countries, not necessarily FGS, but any other disease condition where they have been able to use this, and then we can apply the lessons to FGS?
Yeah. No, that's the weakness of the frame. It's pretty new, but not so far. So which is why I really like to get it out there.
It's an opportunity for us to try it out and see how it works, and then share the lesson. Yeah. Okay.
Absolutely. Yeah. That would be great.
Thanks, Margaret. We've got a couple of things that have come up in the chat. And I think this is a great call out for those of you who are on the line that are considering different programs, that, this is a new framework potentially to apply. I'm going to first, I see there's a comment Millicent I don't know if you're on the line here and would like to share your experiences from Kenya on integration. And then I have a comment from Ashley and Caroline. So maybe Millicent, if you're on the line and willing to share some of your thoughts and on integration and how that could work, considering the framework here. Putting you on the spot, so.
Okay, thanks. In the line, I'm also having my boss, and I'll follow protocols. Yeah, I'll just introduce it briefly, then I'll leave to Dr. Mulupi, who will explain further what we are doing. And I'm just worried about my battery. I'm using my phone. I'm just having 1% remaining. Yeah, so we're doing a pilot in Kenya, and we are targeting 3 endemic counties in Kenya, and that is Homa Bay, Kilifi, and Kwale. And I'm just glad to have seen Carol today, because I've put quite a number of references to the work she's done in our current project. Yeah, so this is just an integration project of female genital schistosomiasis in sexual and reproductive health services in Kenya, in those 3 endemic areas. And we want to assess their feasibility, acceptability, and cost of integrating these female genital schistosomiasis. So basically we work with the MOH, we don't work alone. So there was development of a minimum service package of how this is supposed to be done. So this minimum service package was developed by the FIG team. Then we had to contextualize it to our Kenyan context. And of course, we started from the national level, coming down to the county level, because whatever is done in one county may be different from what is done in another county. So that is what we did initially. And currently what we are doing is to ensure that the healthcare workers are trained, and just as noted by Carol and also other people who have really seen the need of this FGS, there's quite a knowledge gap which is cutting across everywhere. In as much as we've been having schistosomiasis with us for so many decades, but it's still female genital schistosomiasis as a subject is not known even to the medical fraternity. So first, it is literacy. That is the component of the MSP, that is minimum service package. Then we're also having treatment and care, treatment, care, and diagnosis, screening and diagnosis, then treatment and care. So all these, we put them in our minimum service package, and we are training the healthcare workers as the key people who are supposed to really help us with this integration, but of course not forgetting the community health workforce, that is the community health assistants which we are having in Kenya, and the CHS, that is community health assistants, and of course other community health workforce like community health committees, and also even the peer educators who interact with the patients at the community level. Yeah, so the other people we are targeting are also the health managers, because we can't integrate FGS without involving the health managers. So because they are the decision makers. So we are having all those, but I leave it now to my boss to proceed. Thank you.
And
thank you, Millicent, for that summary, a wonderful summary. So very briefly to add to what Millicent has said, my name is Dr. Stephen Mulupi. I head research implementation at LV City Health in Nairobi, and glad to be here in the other conversations that are happening. So to add on to what Millicent says, I think the thrust of our study is that we want to disrupt what we call a vicious cycle of neglect. So you have no services being provided at the healthcare facility because you do not have data about disease burden. And because you don't have data about disease burden, service is not provided. And therefore that denies decision makers at the policy level to allocate resources, because that data has to come from the facilities in terms of the needs. So this study comes in a big way to provide data based on healthcare workers who have been trained and patients who have received care. And we also want to get from them issues like acceptability of services, feasibility, and we do also have a costing component. just understand how much it costs to integrate FGS with normal sexual reproductive healthcare services. So this year we're collecting data, but I think opportunities like this provide an important opportunity to amplify our voices and really put this on the agenda in terms of integrating this at the national level. Finally, just for context, Millicent mentioned counties, 3 counties. So Kenya is a devolved government context where you have national and subnational level. So this subnational level are devolved and have some autonomy in terms of decision making based on their local priorities. And therefore, we hope that this will be kind of contextualize the needs to the service that's being provided. Thank you.
Thank you, Stephen and Millicent, and we'll look forward to hearing we'll look forward to hearing the results of your pilot, and let us know, and we can we'd love to hear them through iCords and the similar lessons learned. Listening to those comments, I don't know, Carol, what you think, but it just reiterates for me the importance of that whole health system approach and the information that's, getting the information into the system that helps to drive action, and the need for a case definition. And, there's so many connections, I think, in those comments that were just made, that we can't just act in one particular domain of the health system, but it needs to be across all domains in order to make a change. I'll pause there and ask you to comment.
Yeah, I think it's wonderful, to hear that. And I think if maybe we could work a bit together in the future on more sort of getting some examples into this framework and making it more realistic, because you have a lot of the elements, maybe all of them, and you definitely have the both sides of both parts. You have the clients or the population, and you have the parts of the health system, and then you have all the different levels. So I'd love to hear more about it. Maybe we can be in touch after this conversation.
We just have a few minutes left, but there's a comment from Ashley, and I don't know, Ashley, if you want to just say a couple words, just given your experience in Cote d'Ivoire and working with the national program there, and just in thinking about this framework. So it'd be interesting to hear your perspective on that.
Yeah, thanks. So hi everyone, and thanks for the presentation. I think, so I was thinking about, in sort of general terms, how the lessons we've learned from working with the Ministry of Health in kind of moving towards integration of FGS services into the health system. And some of the key things are around thinking about what evidence the Ministry of Health actually needs to be able to make those decisions and changes to their policies and guidelines and things. And so I think anything where you have a framework where you can, it's a tool that's usable in those planning meetings, it can feed into that evidence around what can be done and what can't be done is really helpful. And then the other element that's really essential, and I think it's already been sort of mentioned by a few different people in different comments, is thinking about the context and how, obviously, in different settings, you can't just have the same approach across everywhere. So then having the feedback from the different stakeholders at the different levels is such a key part of integration and successful integration, and to sort of understand as well that how the sort of health system works in each country and how it might differ, and what approaches need to be tweaked or changed and what's relevant or not. So I think those are some of the key elements that have been really important in Cote d'Ivoire.
And Ashley's just done a paper and her colleagues have just written a paper. So Ashley, do put it in the chat so people can access your experience that you've just written about, your group has written about. So thanks for being put on the spot today. I appreciate it. Carol, any comments on your side?
No, I don't think so. I think they've been really helpful comments, and I really, I plead that I'm very humble in all of this. It's more, it seems a bit abstract, but hearing your comments, I think, will help to put some real meat into this whole process and to continue working on it. And the fact that FGS is just so, I mean, in a way, it's very unfortunate that it's so neglected, of course, because people have suffered so much. But on the other hand, it's an opportunity to do things right in the future. So I think as health systems start to integrate it, with some of the examples here, this will be some things to keep in mind, that we have human rights and that needs to be respected, and also how to incorporate the gender sensitive nature of it, hopefully leading towards gender transformation in the future.
Absolutely. So we're just kind of approaching time. And I want to just highlight a couple of, and before I go, just highlight, if you haven't had a chance to read the chat, Caroline, thank you for sharing the experience of Malawi, who is going to be looking at incorporating FGS into the national STI and HIV guidelines. So we'll look forward to hearing the outcome of that. And Daniela talked about a diagnostic colposcopy training that is open for healthcare professionals, and has provided the link for that as well. So please reach out to Daniela if you have any questions, or you'd like to join or share that with colleagues. And then Beth Long has also shared some information about the 6-country prevalence study funded through Core NTD, which is underway, which I think will provide a lot of really useful information. And there's also a link to FIG, which has been provided by Christine. So a few really important links there in the chat for those of you that are interested in seeking some more information on this. And we've also linked the paper, Ashley's paper, and also put a link to the paper that Carol referred to here. So in closing, a really huge thanks to Carol and for her time today and sharing with us a really important topic, and one that I think a lot of us that are working in this field, we're looking for frameworks and things to kind of guide our work. And so I think this is a really useful framework that hopefully, now that we've heard more about it, those who are interested in FGS integration at the health system may be interested in testing this framework and seeing how it works. And so we can continue to build on it and grow and learn from it. If you're interested in joining iCords, I have put the link in the chat to the website. We are delighted to have social and behavioral science scientists as part of the community, or people who are interested in social and behavioral science. And so please do join. And finally, I'll just launch a poll. Hopefully did that correctly and you can see the poll. Please do let us know how you enjoyed today's session and if it was informative to you. So Carol, just a final thank you very much for an excellent session, and thanks to everybody for a great participation and engagement with the session today. And we will look forward to seeing you all at our next Knowledge Cafe in February. So stay tuned for more information. It'll occur around February 15th. So we'll be announcing the theme shortly. So thanks everybody. And once again, Carol, thank you so much.
Thank you.
Take care.
Bye. Thank you.